Okay, congenital nephrotic syndrome. Majority is due to mutation in one of the 4 genes, that is NPHS1, NPHS2, WT1, and LAMB2. The protein coded is nephrin, here podosine, and locus 13, locus 1, locus 11, locus 3. The common is the Finnish type of congenital nephrotic syndrome. Okay, this is just for your reference. Isolated glomerular disease with recurrent gross hematuria. Sudden onset of gross hematuria, brown tea or cola like smoky, short latent period 1 to 2 days after upper viral respiratory infection, spontaneous resolution of hematuria within 5 days, recurrence of condition with another respiratory tract infection. Routine investigations are non-conclusive. Renal biopsy is the only diagnostic tool. There may also be present with microscopic hematuria and or proteinuria. No hypertension, no edema, no renal impairment. Here the answer is the IgA nephropathy. So here some important points you have to note. Sudden onset of gross hematuria, short latent period, usually 1 to 2 days after upper viral respiratory tract infection, and spontaneous resolution by itself. There is recurrence of condition with another respiratory infection, and routine investigations are non-conclusive. They will not give you any idea. Only diagnostic tool is the renal biopsy. They may also present with microscopic hematuria and or proteinuria. No hypertension. In IgA nephropathy, no hypertension is seen, no edema is seen, no renal impairment is seen in most cases. So if the case description matches with all these points, you will go to IgA nephropathy. But the options which can be given for you in the questions are all this. Alport syndrome, thin glomerular basement membrane disease, idiopathic hypercalciuria. Next. It is the most common chronic glomerular disease characterized by mesangial deposition of IgA as the only or predominant Ig without evident systemic involvement. So the IgA is mainly deposited in the mesangial deposition of IgA, chronic glomerular disease, without evidence of systemic involvement. Okay, you don't see features like what you see in SLE, HSP. Etiology unknown, immune complex disease it is, genetic factors may be, recurrence in transplanted kidney 15 to 20%. So pathology, mesangial proliferation, mesangial deposition of IgA as the predominant IgG. IgA is the predominant Ig immunoglobulin which you see, and mesangial deposits. Clinical picture, variable presentations. As we read, recurrent gross hematuria, microscopic hematuria or proteinuria, nephrotic, nephritic or combined. DDs of IgA glomerular deposits, SLE, HSP, HIV. Crohn's disease, cirrhosis, celiac disease, rheumatic, ankylosing, and reactive arthritis. Laboratory investigations, urine analysis, you see hematuria may or may not be proteinuria. KFT may be raised in 20% of patients 20 years after onset, not in the beginning, 20 years after onset. IgA, no diagnostic value, increased only in 15% of the patients. Normal C3. So imaging renal ultrasound, invasive renal biopsy. Okay, prognosis, good prognosis in majority. Progressive to renal disease in 20% of the patients after 20 years. So treatment, no specific treatment is needed. Control of blood pressure. What is the treatment of choice for control of blood pressure? We read it before also. The treatment of choice for control of blood pressure is angiotensin AC inhibitors or angiotensin receptor blockers. Next, what else you have to add is omega-3, that is cod liver oil, omega-3, L-C-PUFA, corticosteroids and other immunosuppressive agents may be beneficial in some cases. Remove tonsils to decrease the number of attacks because, as we said, upper respiratory tract infection is one of the predisposing factors for this. So if a child is developing repeated tonsillitis and followed by tonsillitis, there is gross hematuria, IgA nephropathy, better to remove tonsils. This is one of the no specific therapy. This is one of the clue. It's like an aid to prevent number of attacks. Renal replacement therapy, dialysis or transplantation in case if they reach end stage renal disease. So the treatment of IgA nephropathy is control of blood pressure with AC inhibitors and angiotensin 2 receptor antagonists, cod liver oil like omega-3, corticosteroids and other immunosuppressive agents. Not in all, some cases can be considered. Remove tonsils to prevent number of attacks. Renal replacement therapy in cases of end-stage renal disease. Henoch-Schönlein purpura, also known as anaphylactoid purpura. Incidence, most common vasculitis syndrome in children. Most common vasculitis syndrome in children, especially male 2 to 8 years old. Etiology unknown, plus or minus maybe allergy, maybe drug sensitivity, maybe vaccination, maybe infection. Pathology, small vasculitis affecting skin, synovium, GIT, glomeruli, CNS, and testes. Clinical picture, skin rash. Any patient you see, in all the patients of HSP will have skin rash in the lower limbs and the buttocks. Site, any part, usually in the buttocks and extensor surfaces of the lower limbs. Centrifugal. Characters start as violet maculopapular rash, palpable blanch on pressure. To start with, then it will be purpura, rare purpuritic, non-palpable, non-blanch on pressure. Start with it, there can be some blanching with pressure, but later there will be not blanching with pressure. What are the associations? Angioedema of lid, lip, dorsum of hands, dorsum of feet, and perineum. Synovium arthritis, 75% characteristic migratory polyarthritis. You see migratory polyarthritis in these cases. Swollen heart affect movement. Red painful. Okay, so complications of the disease, there can be intestinal obstruction, intersusception, perforation, bleeding gross or occult in stool, hematemesis or melena. Abdominal pain is the most common. 50% GI symptoms. Glomeruli is 25 to 50%. Onset is either during acute phase or weeks. Common name is nephritic. I think we'll stop here. Tomorrow we will continue.